Hi, I'm Stephen Smith with the INNOVATE Retina team. I'm here at Retina Society. We just heard the late-breaking Phase 3 data from the OAKS and DERBY trials, specifically looking at intravitreal pegcetacoplan in geographic atrophy. I want to give a special thanks to the Apellis team for sharing some summary slides with me that I'm going to review with you. The global Phase 3 program, just a high-level overview of the studies that we're going to be reviewing today. So this was a study in patients with geographic atrophy secondary to age-related macular degeneration. There were approximately 600 patients at 200 sites globally in two separate studies. So that's a total of about 1,200 subjects across both studies. Randomization was carried out 2-2-1-1 to pegcetacoplan monthly or every other month versus sham monthly or every other month. The primary endpoint for this study was the change in total area of GA lesions based on fundus autofluorescence, and this was in millimeters squared. This was obtained at 12 months. The end of the study, which is still ongoing, is actually at 24 months. And we're going to look today at the primary endpoint data that read out at the 12-month point. So here's some key demographic and baseline study eye characteristics between the studies. And the only points that I want to make on this slide is when we're looking at the OAKS study specifically under the monthly treatment arm, which is all the way on the left, you'll notice that extrafoveal lesions were present in 42.6% of this cohort compared to less for both the every other month and the sham pooled groups. And in the DERBY studies, this wasn't seen, and there was more intermediate large drusen, and GA lesion focality was a little bit different in the sham pooled group. So very slight characteristics, difference in characteristics between the groups. In general, both studies were well balanced across the patient population. So for the primary endpoints in the OAKS trial, specifically pegcetacoplan met the primary endpoint in the OAKS study with a 22% reduction in GA lesion size. The every other month group saw a 16% reduction. Both of these were highly statistically significant. However, in the DERBY study, statistical significance was approached but not quite achieved, where we saw a 12% reduction in monthly GA progression versus 11% for the every other month treatment arms. Pegcetacoplan reduced lesion growth in a pre-specified analysis of the two studies combined. So if you take OAKS and DERBY and you put both of those studies together and look at those cohorts, there was a 17% reduction in GA lesion growth on a monthly treatment in the monthly treatment arms versus a 14% reduction in the every other month treatment arm. Both of these were highly statistically significant. Now, if you start to look at some different subgroups, the patients with extrafoveal GA clearly did the best in this study in terms of having a greater reduction in geographic atrophy progression. So again, looking at the combined trials and all the subjects with extrafoveal lesions, we're seeing a 26% reduction in GA progression in the monthly treatment arms and a 23% reduction in the every other month treatment arms. Both of these were highly statistically significant. Additional pre-specified subgroup analysis that was interesting and presented today was looking at site location. Specifically, both clinical trials achieved statistical significance if you only included sites that were in the United States. And when you looked at the rest of the world, OAKS study still achieved statistical significance, but the DERBY study, interestingly, every other month treatment in the international sites, subjects treated every other month had a 7% reduction in GA growth, but the subjects treated every month actually had a 3% increase compared to sham. So again, some discrepancy there that as it was discussed today, we don't fully understand why we're seeing this, and I think the team at Apellis is going to continue to look at this and try to better understand why this discrepancy was seen in the US-based sites versus international sites. So now we're just going to shift gears a little bit and look at some of the safety data. Again, this isn't a comprehensive review, just looking at a few of the highlights that were presented today from both the OAKS and the DERBY studies. The first thing I draw your attention to is the completion rate, and the flip side is looking at dropout, right? And so in general, there was a good balance between the OAKS and the DERBY studies in terms of the number of subjects that started in the study and then went on to complete the study. So about 10 to 13% across the groups dropped out, and there was not a significant difference between the sham arm and the actual active treatment arms. COVID-19 did seem to have some effect, as you can see looking down lower on the graph there, COVID-19 impact. There were a number of patients across the treatment groups who discontinued follow-up due to COVID-19. Intraocular inflammation, obviously something we care about a lot as retina specialists. In 2018, there was a highly publicized episode of 4 cases of intraocular inflammation, and the Derby and OAKS studies were actually paused at that time, and it was found that there was some impurity in the drug product, and this impurity was removed and the trial was resumed in 2019. And overall, in terms of intraocular inflammation, this was a very well-tolerated drug. So there were approximately 13 cases of intraocular inflammation. 10 of those 13 were considered mild, and patients resumed the drug treatment. If you take out the 4 cases that were due to a drug impurity that was already known about, what we're actually seeing is that there were only an incidence of IOI of 1.1%. So again, overall, a very well-tolerated drug from a sterile inflammation standpoint. Now, one of the other things that's been highly discussed over the last 2.5 years or so since the Philly study, the phase 2 study of pegcetacoplan, has been cases of oxidative AMD that it seems like complement inhibition, for reasons we don't fully understand, causes an increase in conversion from dry to oxidative AMD. And so again, this is just to remind you the Philly results. In the monthly treatment arm in the Philly study, almost 21% of patients in the monthly arm developed exudation during the course of that trial. Every other month was about 9%, and that compares to 1.2% in sham. And this was unexpected, and so there's a lot of time spent trying to determine why that was seen and to control for that in the OAKS and the Derby studies. So OAKS and Derby were informed by the Philly trial design, and specifically, if oxidative AMD was expected or thought to be more likely based on, for example, the double layer sign on OCT, these patients had pre-specified imaging to help capture and identify these patients earlier. And once macular neovascularization was verified by Mass Reading Center, patients could remain on the study treatment and also be treated on label with anti-VEGF pharmacotherapy. And so again, this was kind of a pre-specified looking, the study teams were looking to see if this could be identified earlier, and I think the retina community has been very interested to see what the data look like. And I think we're all pleasantly surprised to see that the rates of oxidative conversion in both OAKS and Derby are significantly less than they were in the Philly trial. So you can see running across the top on this table here that 5.2% of subjects in the monthly treatment arm in OAKS developed exudation versus 4.7% in the every other month. Sham pool, that was 1.4%. 6.8% in Derby for the monthly treatment arm developed exudation. 3.4% in the every other month versus 3.4% in the sham pooled. And so when we combined and we looked at investigator-determined oxidative AMD across the studies, there was a 6% conversion rate in the primary monthly arm, 4.1% in the primary every other month arm, and then a 2.4% in the sham arm. So again, better tolerated and less of this complication or this side effect than what was seen in the Philly study, which I think is welcome news to the retina community. So in conclusion, we've gone through a lot of data here. We're really excited to see phase 3 results of a drug in geographic atrophy, obviously a disease that right now we don't have any treatments for. And what we can conclude is that pegcetacoplan delivered monthly and every other month met the primary endpoint in the OAKS study. Monthly and every other month delivery of pegcetacoplan in the Derby study did not meet a primary endpoint. Pegcetacoplan demonstrated greater efficacy in patients with extrafoveal lesions at baseline. And study location, either United States or international, appeared to affect efficacy or have some role there, and the reasons for this are not currently understood and are being investigated. In terms of safety, only 1.1% of patients developed IOI in the treatment arms. The majority of these cases were mild, and patients were able to go back on treatment after treating the intraocular inflammation. The rate of endophthalmitis was in line with previous prospective pivotal trials, and oxidative AMD was seen in 6% of monthly treated arms, 4.1% in the patients treated every other month, and 2.4% in the sham-treated eyes, looking at those groups together. And the patients who developed oxidative AMD were able to continue treatment with pegcetacoplan and received anti-VEGF therapy per the label. So we're excited to see where this data takes us as we continue to parse out the results. And as this drug moves closer to being submitted to FDA, we may again have a therapy that's valuable in our clinics to treat patients with geographic atrophy. Again, thanks so much for being part of this story with us at Innovate Retina, and we look forward to continuing this discussion in meetings to come. Thank you.